In this segment, we will hear from leaders on the ground building outreach efforts in their localities. Each of our panelists will introduce themselves and their work, which then we will come back and discuss. So probably the first in this segment is Etching Utino. And I'm so sorry if I have not pronounced your name correctly. First we have this executive director of Being Africa joining us from Kenya. And I think everybody will be this is very exciting to see their work and just learn how they are just working on the ground. So please come and join and introduce us.
Great to be here. Good afternoon, everyone. It's an honor to join you at this important summit. And I'm open to learning, and I'm also glad for the opportunity just to share what Being Africa is all about. Being Africa is a non-profit organization whose main mission is to connect the dots in the fight against non-communicable diseases, or NCD advocacies, if you may. So we do this through research, policy advocacy, community action, and innovation. So for this, you'll allow me to just share a short story. When Salome went for what she thought was a regular checkup, she had no idea that it would save her life. That simple decision led to early diagnosis, timely and successful treatment. And today, Salome is not only a survivor, she is a patient advocate, sharing her story to inspire others and other women just to take similar actions. And indeed, from Salome's story, we learned that early detection indeed saves lives. Yet in Kenya, 9 women die from cervical cancer every single day. 5,000 new cases emerge every year. This is not only heartbreaking, but it's also saddening, because cervical cancer is one of those cancers that is preventable and treatable. The thing is, if we don't take action, or if we don't act, losing women to cervical cancer risks becoming a tragic norm in our society. At Being Africa, we believe that every woman deserves a chance to live a healthy and dignified life. This belief led us to our campaign, Her Reason for Being. Her Reason for Being is simply a multifaceted community-based campaign that aims at advancing cervical cancer prevention and awareness. This is simply because most women were held back because of stigma, misinformation, and barriers to access. So this campaign aimed at reducing the stigma and misinformation, promoting and encouraging women to seek regular screening, promote HPV vaccination amongst young girls between 9 and 14, which is in line with our national strategy, and also to build community champions. We did this in three phases. We did this, we had a project initiation phase, which involved just developing the campaign strategies and constant reviews. We came up with some plan of action and also developed some campaign materials. Our second phase was to move us forward, was to create strategic partnerships with key stakeholders from government, civil society, and subnational leaders. And then our final phase, which carried the bulk of our work, was on community engagement, which involved working with closely with community leaders, community health workers, and religious leaders. In our initial phase, basically, the things that we were grappling with is cervical cancer is one of those cancers that has attracted a lot of stigma. So we needed to come up with a creative way in which this message can actually be receptive or be received by the community. So we had to create a new brand, and through Sally or Salome, who is our voice of survivors, we created this campaign around her because she is the one who's been going out in the streets, telling people about her story. And we knew that working through this, the community will be already receptive. So we came up with a campaign plan. We developed campaign materials that were culturally sensitive. The community that we are talking about is a community that is multi-religious. It's a cosmopolitan community with varying socio-economic status, and it has various cultures that are represented. So we had to creatively come up with materials that are going to be receptive, materials that are going to be accommodative to all the communities that were around there. And a strategic partnership, we worked very closely with the Ministry of Health for the national level, and also to align the campaign to the national strategy. Coming up with working with already the manuals that are there for training, and ensuring that the training is in line with what the Ministry of Health has in place. And then we also work very closely with the civil society and leadership from various parts of the community. At the community engagement, which, as I said, carried the bulk of our campaign, we did, after coming up with all that, it was time to implement whatever we came up with. And from the community, we held cervical cancer awareness campaigns, walks. We used community radio station just to empower members of the community, and also to reach those areas where which were unreachable by other services, and also the remote parts of the community that were not able to sort of get some of this information. We also leveraged on the use of technology, where we were also having weekly spaces, which enabled us to reach a wider audience. And through these spaces, we were getting quite a number of reviews in terms of the impact of the campaign, and also more people joining in the campaign. We also created partnerships and collaboration with community health systems and institutions of higher learning within the community, our target community. One significant thing that we did within our context, we have community health workers and community leaders who did not really have information about cervical cancer. So one of the strategies that we used was to empower community health workers and community leaders with information and knowledge about cervical cancer, and how we can work with the community just to trickle down information and encourage members of the community just to take positive action towards cervical cancer prevention and control, and even management. From all this campaign, we had numbers that are very significant to us, and the numbers that are keep growing even as the campaign continues. Throughout this campaign, we were able to reach over 250,000 people with our campaign messages and everything that we're doing about the campaign. We were also able to get over 300,000 social media impressions for the people engagements that we were having on that. From the partnerships and the collaborations that we were having with other organizations, organizations at the grassroots level. We were able to have over 3,000 women screened for cervical cancer during that period, and through the training program, we were able to train 160 community champions, who included community health workers, community leaders, and some religious leaders. In this campaign, we were also able to forge collaborations that we are still keeping with the 11 health facilities that are already doing cervical cancer screening and other gynecological cancer screening. So indeed, from this campaign, her reason for being still remains to be our reason for being. Because through this campaign, we've been able to prove that communities can actually lead positive change. And now we are looking to scale up this campaign to the next level. Because through partnership, sustained resources, and global solidarity, we are able to make a significant impact. And at this point, we are looking at her reason for being it's actually more than a campaign. It is a movement. It's a movement for dignity, it's a movement for prevention, and it's a movement that supports survivorship. And we believe that together we can ensure that no woman has to lose her life to a preventable cancer. Thank you.
Thank you, Aching, and it was a great to learn you. I know that it is 5 minutes is very less that you have exceeded long back. So it's okay. I think we can't stop you because the story is very impressive, and we want people to get motivated and take this task in their respective country to lead such campaign, so that and this is a very great example of using patient with lived experience as a center of advocacy. So thank you for telling us your story. So let's move on to the next presenter, Vas James, head of programs of the Eve Appeal, who will be speaking on to her and Northeast London Cancer Alliance work on the You Need to Know campaign. So over to you, Eve.
Thank you so much to IGCAN, Roz, Abhishek, Shreya, for all of your support, and to the summit chairs. I'm absolutely delighted to be here and meeting with everyone today, particularly after meeting so many of you in person in Dublin. So my name is Vas James, and I am the head of programs at the Eve Appeal, which is a UK-based medical research and advocacy charity focused on early detection, screening, and prevention of the 5 gynecological cancers. We'll be sharing a summary of our outreach initiative called You Need to Know, and it shares a lot of common themes with Aching's excellent program, Being Africa, so many common themes between these two projects. And I'll finish up with some of the shared learnings that we all share, definitely, and a call to action. And a lot of the calls to action are reflected in Thomas's excellent report that was shared early on in the week. So womb cancer, we call it womb cancer in our community rather than uterine cancer. It's one of the fastest rising cancers for women in the UK. And when you pick apart the data by ethnicity and by deprivation, you see some stark inequalities. So in Northeast London, it's a very diverse community. Women of Black African, Black Caribbean, and South Asian communities are much more likely to present at a late stage in an emergency setting, sort of stage 4, rather than seeking help earlier. And we know the difference that early diagnosis makes. So survival is around 92% at stage 1, but it drops to just 15% at stage 4. And 1-year survival in North London was one of the lowest rates in all of England. Now, when we spoke to women locally, there was a low awareness of that key red flag symptom of bleeding after the menopause. And there was a lot of misunderstanding around cervical screening, picking up womb cancer. So when you couple that low awareness with the stigma and the language barriers and the mistrust that many of our speakers already have spoken about, you've got this perfect storm that leads to delayed diagnosis and poor outcomes. So it's with that in mind that we work together with the Northeast London Cancer Alliance, the University of Leicester as our evaluation partner, and AKT Health, with this aim to create a campaign to raise awareness of womb cancer in Black and South Asian communities, to improve awareness and to support earlier stage diagnosis. So how do we go about doing this? We knew that, similar to what Aching was saying, that a sort of a top-down, one-size-fits-all approach just wasn't going to work. So we set out to work hand in hand with the community. We ran focus groups with women in the community for every stage of this campaign. So that was looking at what messages they were, what languages do we need to use? What image do we need to use? What content and what format of that content and in what settings? And we worked with what would resonate most with the members of the community. We recruited local artists, photographers, and the models in our campaign, you'll see some of the images later, were all from the community, so that women felt that they were reflected in this campaign. We translated our resources to the website and the advertisements and the content into a number of different languages: Bengali, Gujarati, Somali, Urdu, Arabic, and Punjabi. And crucially, there were in-person sessions that we held in trusted places. So places of worship, GP settings, community centers, in the next phase of this campaign that they're running, the nail salons. So trusted spaces where the women are, as Nefertari was saying in her speech as well. So this approach wasn't just about creating awareness, it was about creating trust and ownership with the community. So the campaign was evaluated by a team at the University of Leicester that's led by Dr. Esther Moss. And they have an understanding not only of the science of womb cancer, but also about the inequalities that exist and the communities most in need of health information. That's been published in the British Medical Journal's Focus on Public Health, and I can share that article with you. There's a lot of key lessons from the campaign that I'm sure are relevant for a lot of the work that we're doing, and those resonate with what Thomas has shared in his report. So what did the evaluation share? Well, overwhelmingly positive feedback from the evaluation. 92% of women, over 92% of women said that the information that's go see help if they experience any symptoms. They were encouraged to share what they learned with their community. That's hugely powerful. We raised awareness of that. One of the key tasks was raising awareness of that red flag symptoms of bleeding after the menopause. But I think the most powerful thing is the qualitative feedback. Researchers are often learning. Our women shared with us that was really powerful. Women felt seen. They felt that the campaign reflected themselves and their community, and building that recognition and empowerment was hugely powerful. I think we all know the importance of translation and cultural tailoring. It was reinforced in the evaluation, but I think we're all aware of that. So lessons learned, and Acheng touched on this, and so did Sharon and team. Co-design is all about, with the community, is absolutely essential, and it can't happen at the end of the campaign. It's got to happen through the life course of a project. Keeping messages clear and simple, and not jargon. We'd done outreach sessions with businesses and companies, but actually it was all torn down and rebuilt in languages and images that women felt comfortable using. The in-person engagement was absolutely essential. Digital tools definitely have their place, but when it comes to tackling stigma and building confidence, that face-to-face interaction was incredibly powerful. And finally, evaluation is key. And this is such a big challenge. We were able to deliver the information and have an increase in understanding. Women left the session feeling more empowered and more confident about going to medical community to seek help, but tracking that beyond, so that we're looking at, are women getting diagnosed earlier? That is key, and that's something that we've got to work on. We have a gynae-led nurse support line, and we definitely saw an increase in calls to the helpline, but actually tracking that through to reducing womb cancer cases is a big thing, and it's something that we all need to work on together. What are the calls to action here? What are the broader implications? So for policymakers and funders, it's all about dedicated, sustainable funding. We know, so Acheng's project and this project, we know that these focused campaigns work, but building dedicated, sustainable funding so that we are able, as trusted partners, to go in and tackle these inequalities is absolutely key. For NGOs and advocacy organizations, just like many on the call here, it's again about the cultural tailoring, translation, and co-production. I'm preaching to the choir here because all know that that's important. For health services, we're helping women get to the door, and it's about having accessible referral pathways. They need to be equitable. We need interpreters and culturally sensitive staff, because once women have got to the door, we need to make sure that they are being heard and listened to. From a research perspective, we need to build more rigorous monitoring tools and get an understanding that the qualitative information that we get is hugely powerful, and we need to act upon that. We also need the disaggregation of the data around deprivation and ethnicity so that we can understand where those inequalities exist and so that we can act on them. And finally, just as we're doing now, it's global. What are the challenges and how can we overcome them? So we're so excited that we're here today. I'm keen to learn from you, and whatever I can share with you that you can adapt for your audiences, I'm keen to. This forum is just so hugely important. So, just to conclude, I just want to say that you need to do what we set out to do, but there's just so much more that we can do. I think that the gyne-oncologists on this call are delivering clinical excellence, but we play an important role as trusted partners. We are there on the ground, listening to women, building trust and confidence, cultural contexts, as equal partners. And I think that partnership is key in changing these outcomes. Thank you. I hope I didn't go too over in time.
Thank you, Vasanti. I'm taking your full name, which is very famous in India. People call you Vas. So I think it was an incredible presentation, and thank you for letting people learn about your ground shot work, which is very important in the era of moonshot. So I think ground level advocacy is a way to go out for the LMICs, because I think even United States of America Cancer Moonshot program did not reach to moon finally. So coming to the points, which is, I will request everyone, because this is a great opportunity to ask question to all the speakers. Please write in your chat box, and I think it will be asked to the presenter at the end of this. So thank you so much, and I'm sure that people will have many questions, and at least last the trust partnership. So that is a good thing to learn how to just bridge, because there is many trust gaps among the providers and the caregivers and the doctors. So I think your kind of organization is just bridging the gap, and there's many points to learn in your last slides. So I will wait for more questions to come, and I think you will have to clarify all the doubts, including our doubts too. So the next presenter is the recipient of EDI grants, Eleanor Richards from the University of Manchester. So let's also give her our own IGCAN welcome and invite her to share her screen at this point of time to speak. Thank you. So please welcome Eleanor Richards.
Thank you. Thank you very much. So first of all, thank you so much for inviting me to speak today. Such an incredible event. I've already learned so much, and we're not even halfway through. And thank you as well to the network for funding this project, which was entitled "A Versatile Womb Cancer Education Video for Underserved Communities." So there are a lot of similarities with the work that Vas has done. Part for disclosures, I'm employed by the University of Manchester and I'm funded by Cancer Research UK. So Vas has already covered the womb cancer background. I'll just say some similar things in a slightly different way, which is that in the UK, cancer of the body of the uterus, womb cancer, is the most common gynecological cancer. And as Vas mentioned, there is a significant lack of awareness, with lots of misconceptions and a reliance on the lay health system of communities, friends and family with experience. I just wanted to go into this in a bit more detail because it's very relevant for what we did in this project. So the literature describes that women often with womb cancer feel that the most common symptom of postmenopausal bleeding, there's evidence that people feel like that might have been caused by non-cancer causes rather than cancer causes, which contributes to the delay in presenting to their doctor. there's also this idea that even if you recognize that the symptoms may well be cancer symptoms, that cancer means death, and therefore, well, almost what's the point in going to the doctor, and that kind of stigma around cancer contributing as well to delays in attendance. As Vas mentioned, there's a lot of confusion around what the role of cervical screening is and whether that will detect other cancers of gynecological origin. And similarly, I think, again, that confusion around cervical cancer and this idea that sexually transmitted infections are related to gynecological cancers, and adding to that stigma. Just some data to show that, this is incidence data in America showing that the incidence, particularly in Black women, is increasing at a much faster rate than other ethnicities. And this is mortality data from the UK, showing that mortality is significantly higher in Black women here as well. And it also in the UK, that there is a slightly increased risk of mortality for South Asian groups as well. And I've just highlighted the Pakistani group there because the Pakistani community is one of our largest in Manchester. So this project aimed to develop these educational videos on symptoms and risk factors. Similarly, to the You Need to Know campaign, we also wanted to co-create that with Black and South Asian communities in particularly around Manchester, as that's where we're based. But we wanted to try and see if we could create something that would be adaptable for different populations and different healthcare contexts. And we knew that this project would be, because of that aim of wanting to create something adaptable, this first round would be a pilot, and that we would build on our lessons, and we would require further development in the future to make it as versatile as possible. Once we started this co-creation process, our initial aims and what we were expecting our methods to be were adapted in response to what our focus groups were highlighting to us, and that's something I'd love to talk about in more detail. Our general approach was a series of semi-structured focus groups where we would talk about what womb cancer is, hear from the communities what their key concerns, their key priorities were, and use that to structure what the videos became, and feed that back to the groups, get more feedback. And it was very iterative and a very enjoyable process. And here's some of our focus groups there. Obviously, I am from a very privileged background, and I wanted to make sure that my blind spots were being covered as much as possible. So I invited researchers of African and Pakistani heritage to join me in these focus groups, co-facilitate them with me, and I learned a lot through that process. And as I mentioned, the participants' ideas and reflections were then used to develop this campaign, as well as not just the key messages, but the creative direction as well, which was very exciting. Out of the focus groups, some of the key things that we discussed in regards to the key symptom of bleeding after the menopause, we had to sort of take it a step back, because a lot of our women were saying, well, we don't even feel like we understand what menopause is in of itself. So it's hard to distinguish between normal menopause and abnormal menopause. Again, in this group, that finding of cervical screening and the role of that in womb cancer was raised in this group as well. And similarly to the literature, we talked a lot about fear of cancer, the sense that cancer is a death sentence. And it was felt very strongly that we therefore needed to highlight that womb cancer, although relatively common, is generally very treatable and preventable, and you can live a very happy, fulfilling life after diagnosis. So survivorship needed to be a strong theme in this program. And the most useful way to describe that and address these concerns is to highlight personal stories from people with lived experience of this cancer. So taking all of this information into account, our approach therefore was to use an animation to cover information of the medical side, what the symptoms are, what the tests are that you should expect, and then interviews highlighting lived experience. So I just wanted to give a couple of quick examples of how we developed these ideas. So These are the initial illustrations of potential characters for our animation that were reviewed by our groups. We then use the key messages to create a storyboard that I brought back to the groups to get more feedback on. And using feedback, we then finalized our characters and we made them the colors are brighter. The sense of the group is much more positive. They are hugging each other, they're looking after each other, and there's lots more diversity in kind of religious and cultural clothing in our final set as well, which is really nice. We also used, as I mentioned, videos of women with lived experience of not just cancer, but symptoms, who then ended up not having cancer. And I have a quick example from the video.
So with cancer, it's a word that the community don't really like to use. Cancer is also not discussed, but womb cancer is totally not discussed. If we have awareness, if we know what is the womb cancer, what are the symptoms, we can it can be detected earlier stage.
The science is always advancing. The science is there to help everybody. So it really is not a life sentence. It really is not a life sentence.
There's lots more to come, but I just wanted to give you a little sneak peek. So the next steps for us will be evaluation of the impact of these videos, the animation and the survivor stories on knowledge and behaviour. Dissemination of these videos. We want to approach dissemination through a kind of combination of local and hopefully like national, maybe even international, with the help of the IGCS network. We're going to be planning lots of events to celebrate everyone that's contributed to this process. And as I mentioned at the beginning, there will be future rounds of campaign development, really aiming for something that we can use in different settings as well. So thank you very much to everyone that's been involved in this project so far, with particularly the womb cancer survivors who have shared their experiences and expertise with us, and to our funders, of course, IGCS. Thank you very much.
Thank you, Eleanor, for this presentation. It was so impressive, and thank you for making us learn about your advocacy work. So now I think the format says that we have to just go for the panel discussion. So I will request everyone to please post your question in the chat box so that we can reach out. And if you can specify and mention you want the answer from the specific presenter, so we can just name those presenter and they can answer your question. So I think there's a general question from Saran O'Toole. She has asked a question: is there a standardized set of outcome or impacts that we can all use to measure impacts of campaign and compare effectiveness across countries so that we can learn what is the best? Anyone among you can take this question, or if you want to answer differently, all of you can do this. I think they will get a insight from 3 people. So maybe Eleanor, you can answer it first.
Sure, thank you. My only concern would be with a standardized set of measures is that every community's needs can be quite different. And I do think when you're organizing evaluation of any program, any public health or medical program, what you choose to evaluate should reflect what your goals are and what the needs of the community are. So although I'm sure there are some standardized measures out there, I think that's just something to bear in mind, is that could be a really great starting point, but I think you need to make sure things are as closely aligned to your goals and the needs of your target audience, and go from there. Thank you.
Vas, you want to respond to this question?
It's absolutely right.
Yeah.
What Eleanor says, so I know with Etchings and ours was about raising awareness, understanding signs and symptoms. I think it's that sort of that longer term behavior change, that we measure understanding at the beginning of an in-person session, at the end of an in-person session. You can look at social media metrics, how many engaged with a particular post and website hits and that sort of thing. But I think the challenge, and I'm sure you, Sharon, as well, looking at harm. We know the power of these grant initiatives, but trying to demonstrate to health economists and government that are we reducing the mortality and reducing the burden on the health system. These are bigger challenges, but I think, as Eleanor said, it's taking the smaller steps and looking at our aim was to raise awareness of red flag symptoms and increase awareness of wound cancer, and that was definitely done. So small wins, big challenges and small wins.
Yeah, Etching. So you want to answer this, respond to this question?
Yeah, I think largely a lot has been said. Vas and Elena have actually highlighted the basic challenges that one would face in terms of this kind of evaluation, because largely communities and context tend to differ. So having like a standardized format might actually not work effectively, because there are various dynamics that do change. Like in our context, I gave out a statistic of 9 women dying every year, but those are the women who visited healthcare facilities. There are others who die from who've not gone to any healthcare facilities, and they die from cervical cancer. So sort of this kind of evaluation tend to differ. But I'll agree with Vas. It's a huge problem. We are celebrating small wins. Each and every step that we take, you raise awareness. You get a number of people going for screening, others moving forward, going to treatment and into survivorship. So it's small wins as we keep celebrating. Thank you.
Okay, so I think I will come to the challenges that you all address it. So I just want to know, in just one line, what is the biggest barrier in reaching community at the grassroots level? Just simple, one line. Biggest challenge you find there's a finance, there is a stigma, misinformation, digital access, affordability. What do you think in one line for your project?
Sure.
Yeah.
If I can go first, I think it's the longer term funding. We've had a lot of us are on short term project funding, and we know that these initiatives work, and having longer term sustainable funding to reach more women is vital, and that's just not available. So sort of building these sorts of initiatives into healthcare budgets will be an essential part of tackling these inequalities.
What do you think the biggest barrier reaching communities at grassroots level in terms of advocacy, and what you experienced during your project?
Yeah, I think for me, the biggest barrier that I experienced during this project was sort of knowing where to go, who to talk to, how to start those conversations, how to reach communities in a way that meets them where they are and is respectful and kind and everything that you want it to be when you start reaching out to people who might not have worked with doctors or researchers or planners before. And as I mentioned in my presentation, I come from a very different background to the audiences that I am and the communities that I wanted to work with. And so I think in that regard, having representation on your team of the communities that you're working with and taking the time to really get to know people and follow up with them and build that regular communication relationship, building the trust so that they know that they can trust you and they can come to you and that you'll be responsive. And once you've built that, people are so excited to get involved, and then it just spreads from there, and it's really magical to see. But you've got to take the time to do it well.
You just uttered a very important word, trust. So tell me one interesting story about the trust that you build with the community. Any highlight, with that you feel that, okay, this was the trust and that made me happy in this advocacy work. You remember any such incidences? while connecting with the people, you said, yes, this trust was important, and I just made it.
I think one of the ladies that I had in my focus groups, the group was just supposed to be representative of the general population. So it wasn't planned that there were particular cancer survivors or anything in this particular group. And we were just talking about what do people know about womb cancer? What are your main questions? What would you like to know so that we can design this program? And when I came back to the group the second time, she came up to me and she said, I just wanted to say thank you for talking all of that through. It made me realize that I've had symptoms. So I went to the doctor. I felt more confident going and having that conversation. And that's just, just that little moment where someone comes back to you and shares that they've done that and that they trusted the information that I gave them, and then they trusted me to tell me about it afterwards. Was really lovely.
Basa Neching, your trust moment of your advocacy.
It's the power of trusted health professionals and building the trust in the settings. A safe space is what they often say in North America and here. And in those in-person sessions, you can see women's shoulders. Is telling me there were often questions about basic gynecological health, not just about signs and symptoms of gynecological cancer, understanding periods and pregnancy and the menopause, as Eleanor was saying. There's just so little information, and those massive barriers that exist around stigma with gynecological health, thing to do with gynecology and anatomy even. These are massive barriers. So when you're connecting with women and have these amazing professionals like Eleanor in the room, there is a magic that happens, and that you're empowering people to take charge of their health is really incredible. So I always find those inputs really.
Your trust moment, anything you remember related to, I know there were many, but what is the best moment when you believe that this is the trust moment?
For me, it's actually tied to what Vas was talking about. Actually, breaking the cultural barrier was big for us, because when you talk of gynecological cancers, men tend to shy away from the conversation. Yet, they are a key component in terms of helping, fight gynecological cancers. So for us, breaking that cultural barrier and bringing men into the conversation was a key moment to just smile about and just enjoy the moment and see how best we can carry these conversations forward. So that was our moment. Thank you.
So I just want to know, you said a very important thing. How many of you think that the awareness campaign should be a gender neutral one? How many of you think so? Even you are talking about GYN cancer, how many of you think the campaign related to awareness should be a gender neutral?
I guess it depends on the audience. So we have a schools campaign, and that is for all children. We don't separate the girls out and deliver health sessions for just the girls, because everyone needs to know about body parts, correct, and anatomical terms, and understanding what's happening to half of the classroom. And so I think in those sorts of, it depends on the awareness session. And I think that given if Eleanor and myself were looking at very targeted communities where there are barriers to accessing care. And so I think for those specifically, we're working with women in the room, with female health professionals and community leaders. But so I think it depends on the campaign. But as Asheng said, it's so important to empower the men, and they are keen to know.
And something I would say on that is I think there are two different areas where you can be more inclusive with gender. So there's encouraging all family members of at-risk people, husbands, children, brothers, anyone that could support someone who is at risk of cancer, and making sure that awareness is raised throughout the community, I think is really important. And then there's also making sure that anyone with a uterus, regardless of their gender identity, is aware that there is a possibility of having this cancer. And we made the decision with this campaign that we've been working on to, I don't know if anyone noticed, but in my big picture of all the different characters, there are one or two where I would say that they could fit the non-binary look. And we made sure that the language that we use in that slide, or throughout actually, is that anyone with a uterus could potentially develop these symptoms. And we didn't make it like a big deal, because we didn't want to. There is a difficulty with sometimes adding additional barriers for minoritized communities. They might not necessarily understand the language that we're trying to use, or having as gender inclusive characters could distance some people. But we put them in. We made that decision, and we made sure that our language was gender inclusive. And I'm really proud of that, and I think that's really important. And I hope that that's something that we might pick up on in the evaluation. We'll see.
And
Yes.
maybe in our context, sorry, in our context, one of the key things that we were trying to fight was stigma. And that's why just doing like a general sort of awareness campaign made a lot of sense, where we needed to have everyone on board so that we can actually break the barriers and encourage, more women to go for regular screening and even vaccination. There's a lot of misinformation about the HPV vaccine. So having some of these conversations in a generalized format sort of brings in everyone into the conversation. So one of our goals was to normalize conversation about cervical cancer, and trying to bring each and every person on board, because we believe that everyone has a role to play and everyone has contributions to make, so that we can actually move forward and reduce the numbers and the stigmas. Thank you.
So I think two important comments here I can see in the chat box. Jacqueline writes, men are often the caregivers, so they need to be educated about GYN cancer as well. Very rightly said. Nisi said, coming from a culture where the males remain the primary decision makers and voice for women, it is imperative that males are included. This is the story she rightly defines about the most of the LMICs. And I think this is a very, very rightly pointed. Now it's time that you have to praise about IGCS. So I think this is collaboration. So please don't mind. And please take your heart out in telling good things about IGCS, because we work very hard. And I think, how do you believe that, international organization like IGCS can best support grassroots works that we are already doing? You three are, one of the awardee, without overshadowing or diluting local ownership, because we never interfere that what you are doing, how you are doing, please don't do, because we are not like parents. Okay, so I think now you have to come out and please talk good about IGCS, please. I think Vas will start first, followed by Eleanor, then Etching. So I think you can exceed the time. I don't mind if you're talking good about IGCS.
Dr. Shankar, I think we might need to move on. I'm sorry, because this discussion is absolutely brilliant.
So I think this is the last one. This is the last one. I will wrap it because.
Okay.
I think that so the report that's come out, the IGCS ESGO report that Thomas's video is going to be mentioning, is just fantastic. It sort of touches on the work that we are all trying to do in the community and why it's important and how it can be scaled, the need for support and the importance. And so we are hugely grateful for those that research that can help us go to the policy audiences and government to advocate for more support. It's the evidence that we need. Sort of some of that, the numbers that health economists and government are looking for. I think it's that those reports are just fantastic. So I'm so grateful to IGCS for funding that work, because it's a great tool for us as we go forward and try to do more.
I do think that it's really, I think IGCS and other organizations like this have such a role to play in building up and training and upskilling local community leaders, because I think those local organizations have so much strength and knowledge and experience, and sometimes, but not necessarily the infrastructure around them to support their work. So I think IGCS and other organisations can offer so much in supporting those local leaders. I think that's something we could work on.
Reggie, please, your comment.
Oh, thank you. Just on top of everything else that has been said, I also express my gratitude to IGCS. IGCS is doing a good job. I know this is it's a very wide pool where you need to do so much to get some impact. Grassroots advocacy is among those advocacies that are lowly funded. And IGCS just stepping in and giving that helping hand to organizations like Being Africa Online Voices, just to advance the causes, is something to cheer about. So thank you so much for the support. And also I just realized that there is a new series, the IGCS series to eliminate cervical cancer, which is something that we are very keen on, and we'll be looking forward to see how best we can partner in the same, just advancing the cause as we meet the WHO strategies to eliminate cervical cancer. Thank you so much.
So thank you, everyone, for making this panel discussion so lively and answering the question. So now I think coming to the next segment, this is the last presentation. So I would like to welcome Dr. Thomas Hofmarcher, a health economist from Swedish Institute for Health Economics, on the current collaboration between the grassroots advocacy work, IGCS, and his work in cancer policy. So please, Thomas, looking forward to hear you. Please.
Hello, everyone. Thank you so much for the opportunity to be part of this summit. My name is Thomas Hofmarcher. I am a research director and health economist at IHE, the Swedish Institute for Health Economics. Today, I would like to give you an overview of our latest policy report on women's cancers, and I'll try to talk a little bit about how to go from the grassroots level that you have been talking about to the political level and the level of decision makers. I'll share some slides right away. So the report is called Bridging the Gap in Women's Cancer Care, a global policy report on disparities, innovations and solutions. And this report is joint work with my colleagues Andrea Manzano and Urshka Koshir at the Institute. And for this report, we are very grateful to have received financial support from Merck MSD. And in terms of the methodology, our main objective was to provide a comprehensive overview of the burden of and disparities of women's cancers, as well as opportunities for improvement across the care pathway. And our geographic scope was global, but we have evidence from all major regions in the report. And we relied partly on a comprehensive literature review and in-depth interviews with leading experts. And more specifically, we received input from two organizations, the Advanced Breast Cancer ABC Global Alliance, and also from IGCS, the International Gynecologic Cancer Society, for which we are very, very grateful. And we are also proud to have received the endorsement of both of these organizations for our final report, in addition to IGCAN and the World Ovarian Cancer Coalition. And essentially, the report tries to describe the characteristics of women's cancers, the socioeconomic burden, the potential to address them, and also what's important for the policymakers, the investment case for women's cancers. So how much money do you get in return from investing in women's cancers? And then finally, our recommendations on how to improve the situation. So let me start with the characteristics of women's cancers. I'm sure all of you actually know what I'm going to talk about now, but let me just recap some of the findings that we have in the report. Women's cancers, we define it in the report as breast cancer, cervical cancer, ovarian cancer, and uterine or endometrial cancer. The latter three are called gynecologic cancers. And what makes them special? Well, on the one hand, I think there are like two layers. The first layer is that they affect women, and women, as opposed to men diagnosed with cancer, face distinct challenges posed by gender norms, cultural expectation, and structural inequities that might differ across world regions, but they're always there. And the woman being the center of the family, if she's diagnosed with cancer, then that really affects not just her, but the whole functioning of the household and of the family. And the second layer is that women's cancers, as opposed to other cancer types that affect women, carry additional layers of stigma and emotional burden because they might more profoundly affect body image. For instance, if you have breast cancer and you have your breasts removed, or they affect fertility and sexual health. If you have uterine cancer, you will most likely have a hysterectomy and have your uterus removed. And then there are many women that question themselves, am I still a woman if I don't have breasts, if I don't have a uterus? So there's a big emotional burden on self-esteem that women have to deal with psychologically. And when we look at the patient numbers, that's always an important starting point, an important message directed to the policymakers. How big is the problem? And there are 3.7 million women around the world that are diagnosed with women's cancers every year, and 1.3 million women die from them. And we also know that based on projections, there will be increases in those numbers. So until the year 2050, we expect to see more than a 50% increase in these numbers. And we also know that the burden is growing fastest in low and middle income countries, with Africa actually expecting a doubling of the cases from now until 2050. When it comes to the socioeconomic burden of women's cancers, we try to distinguish between two levels. On the one hand, we try to distinguish between effects that women experience on the individual level or the family level, and then on the effects on the societal level. And when it comes to the individual level, of course, there are the impacts that cancer has on physical health, on mental health, on the body image, self-esteem, but also family life, the need for informal care. It will affect your work life, which then also will have implications for household finances, together with treatment payments for treatment, out-of-pocket expenditure, and so on. So those are the individual level impacts. But on a societal level, and this is important again for the policymakers, women's cancers, they cause for them healthcare expenditure needed to diagnose and treat the disease. But what decision makers tend to forget is that they only look at what's above the surface. So I try to visualize this with an iceberg. So they only see what's above the surface, their health expenditure, but they don't look what's beneath the surface. And beneath the surface, we find indirect costs from women being on sick leave, temporarily or permanently, and from dying prematurely, because those consequences have real life effects on economic productivity, which is something they should care about, but usually these costs are not considered by healthcare decision makers. And when it comes to women's cancers overall, then around half of the total societal burden is above the surface, and the other half is below the surface. So by disregarding indirect costs, we're missing half of the picture, actually, from a societal perspective. We also devote a great part of our report on trying to explain the potential to address women's cancers. And in fact, the potential to address women's cancers is high, but it differs between cancer types, and it also differs along the care pathway. So for instance, when it comes to prevention, the potential to prevent different kinds of women's cancers, we know that for breast cancer, the potential is low because it's only around 20 to 30% of cases that are related to modifiable lifestyle factors like obesity, physical inactivity, alcohol consumptions. Whereas for cervical cancer, we know that it is the HPV infection that causes cervical cancer, and we have the vaccine. So there's full potential to prevent it. For ovarian cancer, it's very low. For uterine cancer, it's medium. When it comes to detection, there are established screening methods for breast and cervical cancers, but we don't have screening methods for ovarian or uterine cancer. When it comes to diagnosis and the potential for biomarker-driven personalized treatment, again, it's high for breast cancer, whereas it's more limited for gynecologic cancers. And in the treatment area, the number of new medicines that have been approved over the last 30 years, we see the same picture, that there are many medicines for breast cancer, but only a limited number of new medicines for the gynecologic cancers. And on a political level, a global level, there has been a lot of focus in recent years on breast cancer and cervical cancer due to global initiatives led by the World Health Organization, the WHO, whereas there are no such initiatives for ovarian cancer or uterine cancer or women's cancers overall. And in the report, we point to a lot of challenges and opportunities that exist across the cancer care continuum and that vary by region. And so some of the cross-cutting challenges that we see is health system financing and coverage. It's varying levels of health literacy. So women don't understand why they should go to screening, that it might benefit them. Workforce shortages of healthcare professionals limit access to diagnosis and treatment. There's a lack of infrastructure for diagnosis and treatment, and there's also fragmented care pathways with multiple providers that make it difficult for women to navigate the care pathway. And at the same time, there are many opportunities. So examples are for healthcare decision makers to adopt a societal perspective. So not just look at what's above the surface of the iceberg, but also look at what's below. Patient navigators and providing gender-sensitive care is very important. Leveraging trusted voices in the community to build high levels of health literacy has been shown to be very effective. Using AI, artificial intelligence, to shift tasks in the diagnostic process and address workforce shortages is something that's a great opportunity, actually. More efficient use of radiation therapy is another opportunity. And last but not least, access to new cancer medicines with high clinical benefit, because there are more and more new medicines that really have shown great promise in clinical trials, and it's important to prioritize access to at least a subset of medicines that are highly beneficial. And apart from the innovations that do exist and the potential to address women's cancer that is high, what it really takes in the end is political willingness to make a difference. And in the report, we tried to pull together many examples of existing success stories in the area of prevention, detection, diagnosis, and treatment that exist in both high-income countries and low and middle-income countries. And I think there are learnings that countries can draw on from each other. So if you're low and middle-income countries, you don't always have to aspire towards what high-income countries are doing, but you can look at to your peers in your income bracket and mimic initiatives, such as, for instance, the Women's Health Initiative in Egypt, which is now about to be replicated in Algeria, for instance. So relying on learnings is important, but it's important to get first the buy-in of politicians to actually do something. And talking about the buy-in from politicians, how do we get the buy-in? Well, if you want to get the buy-in from politicians, you have to talk about numbers and about money. Because at some point, there will always be the question, okay, we can invest something to improve care, but what do I get in return? So making the investment case important. And the question is there an investment case for women's cancers? And in the report, we show, yes, there is an investment case, because by improving the care, you're not only improving the health of women, and saving lives, but you're also contributing to longer workforce participation of women, to increased economic contributions, to decrease dependency on social support, and so on. And therefore, investing in women's cancer care is not only a public health imperative, but also an economic strategy. And more specifically, how high are the returns? Well, studies by the WHO have shown that investing in breast cancer or cervical cancer, for every dollar you invest in improving care, you get around $3 to $8 back. So there's actually huge returns on investment. Imagine you spend $1 and you get 3 to 8 back. But it still requires this initial investment to make sure that there will be returns. Now, finally, our recommendations in the report. We have 4 main recommendations. First one is on continuing to raise awareness around women's cancers and advocate for women's cancers as a health priority and smart investment. Then the second and third recommendations are really about the existing tools that we already have to address women's cancers. So accelerating prevention, early detection, strengthening and streamlining cancer care delivery. And the fourth one is about leveraging innovation that exists and then continues to be built across the women's cancer care continuum. But at the same time, there are also these purple enablers that you see on the slide, because ensuring, for instance, universal health coverage is really the basis of making sure that all women have access to the basic diagnostic services, basic treatment services in an equitable way. Investing in the workforce is important. Embedding gender equity aspects is very important, and also building robust data ecosystems, because without robust data, we cannot make an evidence-based case for instance, investing in women's cancers. My final slide now is on how can policy reports like the one we have produced now help to move the needle. So how can they help to create will? And I think it's about thinking about the ABCDE that you see here on this slide. It's about creating awareness around the topic, why it is important. It affects millions of women every single year. It also will affect the budget of healthcare payers. And there's also a cost of inaction, because if we don't act, then the number of cancer cases will continue to rise, the number of deaths will continue to rise, and there is not just the lives that will be lost, but it also has an economic impact. So again, what is beneath the iceberg is something that needs to be considered. Data is important so that decision makers understand what to do, and creating emotions is important. And that's actually, really what I think combines a policy report like this with advocacy that is going on the grassroots level, because it's really about combining these two efforts. On the one hand, relying on patient stories when you talk to policymakers in order to speak to their heart. Whereas evidence-based reports, they should speak to the mind of policymakers. They should provide the data and the evidence, but it's very important to speak to the heart first, and then to speak to the mind for them to lead them into the right direction and really make a difference for patients. So with this, I'd like to end my presentation. Here is a QR code to the report. Thank you again for the opportunity to speak at your summit. It was a great honor for me to be with you, at least virtually. Thank you. Bye.
Thank you, Thomas, for this, and many congratulations for this great write-up and the policy documents, which may have a greater impact in delivering the evidence-based GYN cancer care, because it's talking about the disparity and recently presented during the 80th United Nations General Assembly in New York. So many congratulations for the whole team, and we were one of the partner, our team, I think led by Dr. Glossful. Just we contributed through the expert, and I think it was a great collaboration. So thank you for allowing us to partner and to contribute to this. So now I think going to the next segment, we will have patient and advocate involvement in gynecology via Community Advisory Board. This is a very important topic, and I think many of the people wanted to know more about community advisory boards.